Hi guys, and welcome back to my channel. Finally, after 945 years, I've decided to get back into my vlogging era, and this vlog is basically going to be my experience attending the anesthesia conference. If you don't know what that is, it's basically a congress, a symposium, a gathering of anesthetists from around the country, both in private and in state. And it's just a really great opportunity to impart knowledge and to just learn new skills and practice and learn from the best. And I've been looking forward to this for so long, and I'm so excited. A little life update: I am done studying, internship, everything. I think my last vlog I did mention that, and I'm now practicing anesthesia, and I'm very excited. Yeah, I'm gonna take you through the next couple of days. It's actually a 3-day congress, but I haven't vlogged the first day. I'm only vlogging now. It's the second day. And now vlog the very last day of the congress as well. So I will not make an outro because I know I'm going to be very tired at the end of the vlog, and I'm late with a stain on my top. But yeah, what else is new? Yeah, I'm going to be very tired. I'm not going to make an outro, but I'm just going to get you through the stations and the interesting things that we're doing. Probably won't talk you through the things, but yeah, it's exciting. So keep on watching. Am I late? Maybe I'm late, but let's get in here. Anesthesia conference, baby. Let's go. I made it just in time. Okay.
Awake nasal endoscopy not done as we had the CT, so we knew what the anatomy was. So doing nasal endoscopy can be quite useful. If you have a small scope, a bit of lubricating in the nose, you have a little look and you can see what the glottis and everything looks like, so you know, am I going to run into problems or not? So the problem with ENT cases where there's tumors or swellings or what, the more information you have before you go in, the better. So what are you going to do?
Here in Namibia once again. It's a lovely pleasure to be back and to see some old friends and to see some friends I haven't met yet. So I'm going to be talking a little bit about awake intubation, and just interested to know, by show of hands, how many people in the room regularly do awake intubations? I'm going to nebulize it through a high flow oxygen system, and I'm going to tell you why I think high flow oxygen is really valuable as we proceed, right? So you can do this at the standard neb mask, but this is just a nice way of doing the whole system right. I have to keep that the right way up so that it will nebulize. That's into the posterior nasopharynx. I'm against the posterior wall. Guys, my nose is just as sensate as all of yours. My gag reflex is perfectly intact, right? I'm not some kind of freak. Okay, maybe I'm not. But I can only do this because of good topicalization, right? When you feel yourself in contact with the posterior nasopharynx, then you can spray a bit there. I try and get the patient to inhale because I'm trying to get some of this on the cords as well. If the patient coughs, you tell them that's great. If you're coughing, it means we're covering the places that need to be covered, right? Right, so now that thing that's moving, if only this guy would stop talking, that thing that's moving is the soft palate. And this is what I call the Lara Croft point, because if you've played Lara Croft Tomb Raider, you know that occasionally you have to dive off something into a pool of water, hopefully not a pool of lava. And when we reach this point here, that's where I'm going to dive. I'm going to dive down into from the nasopharynx where we are, down into the oropharynx.
Wow.
Okay. Now, I want a gentle and steady approach. The patient seems to be quite comfortable, and I'm sorry if the picture is not the way up that you're used to. You need to become position agnostic when you do this. Okay, and we're going to approach, and then we need to make sure that our cords are adequately topicalized.
Oh my god.
Okay, so I've got some lidocaine in a syringe with lots of air. I'm thinking about advancing your tube, which you've preloaded, right? Lots and lots of jelly, steady firm pressure through the nose, and now you can think about turning up your analgesical sedation or thinking about giving small aliquots of your induction agents.
It's right in his trachea. Oh my god, you guys.
So I hope I've convinced you that
It's possible.
awake intubation, if you approach it systematically, you topicalize really well, you follow the guidelines, and you are skilled obviously in using the devices.
This tea room break. I'm gonna get some coffee. We're on a break right now, and then we're going to go back in to do some demonstrations. And I'm so excited. So these are the stations that we're going to be going through. I'm vlogging. Tala.
Yeah, you put it to the septum just to avoid trauma because of that.
Okay. And then once I reach the back,
Yeah,
then I
you can
flip it.
release.
Okay.
Scope, and I go into the airway, and I'm using the video laryngoscope to help me get in the ballpark. And now, when I can't see on the video laryngoscope any longer, I can use my rigid scope to make the final approach.
Yeah, that's a nice one.
And then just kicks free, and we're in.
Perfect. You can say hi.
The double lumen tube. Can you identify, is this a left or a right sided tube?
This is the left.
Okay, how do you determine that?
It's going to left side.
Fantastic. So, in the absence of a left or right sided double lumen tube, you can still isolate the lung, or you can still have lung isolation, and you can still ventilate one side or the other. And the alternative. Okay, so you watch the screen now. So you push past that. You stop there. Okay. So you can advance the water rocket. Okay. This resistance is now sitting across the perimeter. Then your assistant while you're watching, your assistant can then say, fine, can you inflate the blue cup? So I'm going to inflate the blue cup. So you need to go down a little bit further so you can see. So the blue this time is going to the left.
Yeah.
So you can see the blue, the cuff inflated on the left side. Yes. Okay. So for confirmation, we then tighten it. So you just concentrate on the scope and this let your system help you here. I then connect this to the 50mm connector here, and then when I ventilate, the right side, because you block the left. So you've got visual confirmation. You also contain the chest, and you've got confirmation that you've blocked the side you want to block, and you're ventilating the side you want to ventilate. So the side that is no longer ventilated is now safe for surgical access if they want it to. If it's a question of you've got an open wound to the chest and you can't ventilate, it means you've isolated that side. You can now ventilate the side and you've reduced your shunt.
Just tell me if this is too big and then I'll just tighten it for you. Is it fine? Yeah. I think this might actually be now it's fine. Okay, so these they work. So are you able to reach out and just click continue? Yeah. Okay, I think it's on me or normally this one. Oh, okay. Is it letting you continue? Yes. Okay, it should have given you a menu now.
It gave me a patient lying in front of me.
So it's gone straight into somebody hasn't finished their sim. So I do this, your thumbs and index fingers together. Yeah. Are you holding the stuff? Yes. Then you can pick it up and move to your patient. 5 minutes to go. This thing here.
So you want to keep it in that position where you want to go?
Yes. With much difficulty.
That looked very smooth. Yeah, so then by the
What's
carina,
happening in the
you can go. You can see what's there. There's nothing in that big.
Straight here, come out, front first, and then just blood everywhere. There, and there. One is like that.
Then you retract towards you.
Yeah, downwards towards me.
The scalpel,
Towards me.
yes, a bit.
The studies were saying like to go up on top.
Okay, I think there are different ways.
Yeah, the different ways, okay? So once that's in, yeah, that's in.
Your assistant.
So once you reach the skin, you kind of like twist, okay?
Then I take this one out because it's not so long. Then I inflate while I'm holding it. Okay.
Okay, so it's 3 o'clock and we're done with the Congress, actually. So there's another day that we're going to do more of the workshops. I don't know what tomorrow is all about because this was airway that I did. And I think tomorrow we're going to have like lectures with everybody else.